Good afternoon, everyone. Thank you for coming to Grand Rounds. As you know, the theme that we're using this year that runs across many of the presentations here has been issues of international and global health importance, and this topic today is certainly relevant and very important as part of a worldview of thinking about what kinds of problems come or affect things beyond the United States. Our speaker today is, for me, an old and dear friend, and it gives me enormous pleasure to have her here and to have her speak with us today. Roberta, otherwise known to her friends as Bobbi Ryder, is the CEO and president of the National Center for Farmworker Health in Buda, Texas. It's just south of Austin, for those of you that may need a little better geography for something a little better known. Bobbi's been involved with migrant workers starting at the age of many of our students in her early 20s, looking after child care and healthcare facilities, being involved with healthcare facilities for migrants, and then 25 years ago started with the National Center for Farmworker Health and has been there all this time, and as I said, is president and CEO. I could go on. Bobbi has studied in a number of places. Her formal degrees from Michigan State University. She's originally a Michigander, and that was where she first ran into migrant workers in communities near where she lived, and became interested in their work and their plight to a certain extent that you'll hear about. I first heard Bobbi speak, I don't know, it's 20 or 25 years ago, when I was doing some work with the Agricultural Safety and Health Center in Kentucky, where we hosted a national meeting and asked Bobbi to come give the keynote address. I had the good fortune a few years later when I went on to the University of Texas before I came here to start another ag center, which I did, and it was the Southwest Agricultural Health and Research Center that's still operating, and we were delighted that we could include the National Center for Farmworker Health as part of those activities. I'll just put the issue to you very simply. No place in the world do people pay less for food than here in the United States. We eat too well, we get cheap food, we get lots of it. But the story you're going to hear today is the price that others pay. You may have heard from time to time, the phrase cost-benefit analysis. Somebody's paying the cost and we're getting the benefit. And it's that story that Ms. Ryder is going to share with us today, I think. Her title is Health for America's Harvesters, and again, it gives me great pleasure to introduce Bobbi Ryder.
Thank you very much for coming. It's my pleasure to be here. I have a few things on the table that weren't at the back of the room and a couple extra magnets for people that I'll put there just to kind of introduce you to the organization that I work for. And I want to be sure that I speak to all of your interests, but I don't know what all of your interests are. So I'm going to present my slides to you, and then hopefully we'll have some time, about 20 minutes at the end, to talk. And in Spanish, una charla. How many bilingual people do we have here? Spanish, English do we have here? So, okay, so we want to have a charla, okay? I'm going to see if I got the right button here on the computer. There we go. I'm going to start out talking about migrant health basics, and I appreciate the introduction. I would add that when I talk about Health for America's Harvesters, I use that in the broadest sense of the term America. Sometimes we're sort of geocentric and we think we are America, but there are other parts and other continents, and many of our agricultural workers here today come from other parts of America. So Migrant Health Basics, I should tell you that I work with a very large network of community and migrant health centers. All in all, there are about 1,000 corporate entities that are private, nonprofit, community health centers and migrant health centers that serve more than 30 million patients. But to bring it down to home to where I am, I work with a very small, manageable component of those network of those corporations, and they are the Migrant and Community Health Centers. There are 156 of them. They're located in almost every state except for Nevada. Collectively, they run 700 access points or health center delivery sites, and they are serving just under 1 million migrant and seasonal farm workers. Because they're migrant and community health centers, they're also serving several million community residents who are there on a year-round basis, but right around 1 million agricultural workers. And to put it in context, we believe that there are about 3.5 million agricultural workers in the United States. So I'm going to share some of the basics with you and a little historical perspective. So we'll get into part 2. One of the things that you will find in any culture or any environment that you work with is that it's like learning to speak a new language. And I'm not going to teach you all of these words or these acronyms, but I would hope that this series, these slides would be available to you electronically so you can look at these. But as you move into the public health and primary care field, these might be of use to you, so I have them here. We have some learning objectives having to do with outlining the history and evolution of the U.S. dependence on immigrant and migratory labor, explaining farm worker demographics in the U.S., including conditions, and then describing the migrant health movement, which I've just generally introduced you to. So we're going to just move right into the history. You know, in this country, we had a movement that preceded the Bracero movement that happened during the Dust Bowl days in the 30s of the United States, in which large numbers of Anglo-U.S. citizens, residents, migrated to California, and a little-known fact is many of them migrated to other areas of the country where there was agricultural employment available, including southwestern Michigan, where I lived and worked. But the huge influx of immigrants came to this country during the 1940s when the Bracero Act was signed between the United States and Mexico. Bracero comes from the word brazo, which means those who work by their arms. And so we had workers that signed up to come into the United States in 1942. Additional migration patterns here, the 1950s, large scales, 1850s. 1917, we did have an Immigration and Nationality Act in which 73,000 Mexican workers were imported, which was big numbers for back then. Continued immigration during the World War I, Dust Bowl, which I referred to earlier, and then the Bracero Act between 42 and 47. What was really interesting to me was that Public Law 78, which was the Bracero Act, was reauthorized in 1951. The Bracero Act was Mexico's contribution to the Allied war effort. Mexico didn't actually go to the European war theater, but because of the loss of farm hands and farm boys on U.S. soil, that was Mexico's contribution. And so it's interesting to see that what was initiated as a response to the war was continued well after the end of the war in 1951. And so here are examples of photos that were taken in the 1940s when this large, and I hate to call it an influx because that dehumanizes it, but these large numbers of Mexicans. And if you've ever done want to do any reading on this, there's a book by the name called Macho, which talks a little bit, not about the sexist perspective of machismo, but it's a very interesting book written that talks about the experience of young men waiting on the Mexican side of the border for weeks to try to get processed to come into the United States. And again, the registration, the process starts. These are not 4 family members. These are just 4 random people who happen to be in line together getting their photograph taken because it was more efficient than individualizing it. Doing individual fingerprints on each worker, physical exams, and there's a little ignominy here. Vaccination, just line them up and give them their vaccinations. They each had individual contracts, and these contracts allowed for the withholding of 10% of their wages by the U.S. government that was supposed to be passed back to the Mexican government as an incentive for them to go home and collect their withholding and make sure they didn't stay in the United States. And one of the greatest travesties was that the U.S. never actually conveyed those dollars. So well after the statute of limitations had expired, there was a lawsuit in the 1970s against the U.S. government in which those funds have now begun to be repatriated to the workers, or if they've deceased, their workers' families, because it was such a significant amount of money. And then waiting for work. I love the hats of the day. So then in addition to that series of migration, there was the H-2A program, which exists today, H-2A applying agriculture. In 1962, John F. Kennedy signed the Migrant Health Act into law, authorizing funds to provide health services to the population. And that was the beginning of the creation of the migrant health centers. Finally, in 1964, the Bracero Act, or Public Law 78, was terminated. Again, we continued to take advantage of that Allied war effort well beyond the end of the war. And today we have the H-2A visa program, which is the only legal method for importation of agricultural workers to the United States. 1996, the Health Centers Consolidation Act was created. You know, there's something missing here, and that was that in 1967, the Community Health Center Act was created. So we had 5 years of migrant health that proved that there was a demonstration that could model creating the availability of primary care services in underserved areas, and that was expanded to include other than agricultural workers in 67. So then in 1996 we consolidated migrant, homeless, and community, as well as public housing services into one act, and then also recognized the inclusion of aged and disabled farm workers as eligible for migrant health services. 2001, under President Bush, we had a huge expansion, and we've literally doubled the amount of money and the number of community health centers that are available to serve people across the country. Of course, 2009, the American Recovery and Investment Act, and 2010, the Affordable Care Act. All of these have pumped large amounts of money into primary care. So why is that important when we think about public health? The primary care services that are required include health education and behavioral health, as well as dental and medical. And so it is important to have points of access to care, because public health alone doesn't help to solve the problems that we have across the country. The farmworker population, a little bit about them and background. Demographics, it's made up of men, women, and contrary to popular opinion and law, children. In agriculture, if you are 12 or older and your parents are in the field, you are allowed to work, and that's different than other industries. This beautiful abuela here on the left is an example not only of the age of people that are working in the field still, but sometimes families traveling intact, with the abuelas responsible for the cooking and feeding and caretaking of the children, caretaking of the whole family, but care of the children who don't work. Estimated population over 3 million, largely foreign-born and Hispanic, with some Anglos, African Americans, and sometimes Asians coming into the population. Largely male, not so high in the educational levels, and a significant lack of insurance, 92% without insurance, and then poverty levels, with Spanish as the dominant language. We do have large numbers of individuals coming in from the indigenous communities in Mexico, like Oaxaca, where we have people that do not speak Spanish. Triqui would be one of the languages that they speak. So that presents a lot of challenges for us. Texas, California, and Florida are considered home-based states. Interestingly enough, if you look at the state of Washington, that's got almost as many people I'm going to look for my pointer here. Point it in the right direction. Okay, here we go. Washington is actually considered a home-based state because of the temperate climate and large numbers of farm workers that are settled out there and go over to work in Idaho. I've been right up here on the border of Idaho and Canada, where Bush Anheuser has a hops farm. And large numbers of farm workers, literally, I mean, I could touch the fence, the border between Canada and the United States. So a lot of migration, we'll look at migration patterns in a moment. We do differentiate between migratory agricultural farm workers and seasonal workers being those who stay under their own roof and go out on a daily basis to work in fields, and migratory being those that move from place to place to place, because there are significant occupational differences as a result of the migration, and it makes it a lot harder to treat as well if they're migrating around. So we used to say that we had basically a California to the northwest. Let's see if I've got my flip side of my geography right here. Okay, California up into the northwest, Texas into the Midwest, like fingers on a hand, and Florida and up into the northeast, including migration from Puerto Rico into New York and Pennsylvania. And nowadays, you cannot predict it. We're doing national as well as international migration with some hubs of places, people that just stay in one spot and move around but don't travel internationally. Current immigration law has limited out migration or people going home because it's so hard to get back in. When I started in Migrant Health in southwestern Michigan, it was largely a Texan population that came to Michigan, and now, for the most part, it's an immigrant population. Largest home-based states, I've given you that information. Fewer families traveling together and more males traveling alone, again, presenting different health challenges. Nationally, 58% of them are renting housing somewhere, 21% supplied by farmers, and others who live off the farm. And these are actually current photographs as opposed to ancient photographs, like some of the others that you saw earlier. Less housing available, a lot of barriers to renting, including a requirement of deposits and qualifying credit checks or long-term rental commitments, lack of cooking facilities and running water, inadequate washing facilities. Availability of work is dependent on the season and the weather. And so, I have a job that is basically 52 weeks out of the year with several weeks of vacation when I get a chance to use it, and nice benefits. And these are people who even when they have work on a daily basis, it may not be 8 hours a day, or it may be 15 hours a day. A lot of labor contractors involved in the employment because there is less liability for the farmer in that arrangement, and a lot of folks still being paid cash these days, so they're not on the books. 79% paid by the hour, while others paid by the piece rate. Average hourly rate is $7.25. Which is a little higher than the minimum mandatory. No sick benefits, no retirement, no unemployment insurance. Workers' compensation, not all states are required. Well, let me put it this way. No states are required to provide workers' compensation benefits, and many states have opted out. Few have health insurance, and of course, no vacation or overtime. 22% using need-based services, in other words, need and demand. Agriculture consistently ranks as one of the 3 most dangerous occupations in the nation, and in 2006, 33 out of every 100,000 farm workers died of work-related injuries versus 4 out of 100,000 in the general population, so significantly higher. Risks and injuries, and just some photographs here to share with you the types of work that they're conducting and engaged in. I've watched an individual who was working on piece rate on ladders, picking apples, and he was up on a ladder, about 3/4 of the way up on a very tall ladder. I'm sorry, I can't tell you how tall it was. And he would pick the whole area that was within reach of his ladder with a big heavy canvas bag on his back that he was chunking the apples into. And when he got done clearing that area, he hopped the ladder around to the next section where he could reach, because it was more efficient than climbing down and moving the ladder. So not something I would be able to accomplish. And of course, this woman with the bucket on her head looks like it's something out of a third world country, but this is actually a Haitian worker in Florida. Stoop labor, as well as the reaching and the lifting that you see there. Broken and crushed bones from tractors and machines, falls from ladders, lacerations, suffocation from silo accidents, and eye injuries. Are you familiar with the Healthy People 2020? Is that something you're all oriented to? So if you look at the accident rates and look at them for Hispanics and look at the disparities between the Anglo population and the Hispanics, you'll see a lot of this in that section. Injuries from vehicle accidents, unsafe transportation of worker crews, and frequent migration. When I worked directly with farm workers in Michigan, I knew families. I did daycare and Head Start for a number of years, and I was the one local resource that they could come to when they needed help, and I would find cars full of families that had 8 people in it with the baby sleeping on the window ledge in the back of the car when they would pull over to the side of the road at night. It was not unusual for these heavily overladen cars with no seatbelts and too many people in it to be rear-ended on the highway at night. They often traveled at night because they felt like that was safer, but they were traveling slowly in overburdened vehicles, and it wouldn't be unusual for trucks to rear-end them as they were traveling. Environmental risks, and one of the handouts that you have is our spectrum of environmental to occupational risks. And there's no clear delineation between the two, with a lot of behavioral issues in the middle. Sanitation, chemicals and pesticides, and I know there's a lot of interest in that on your part. Weather, plants, animals, all critical issues for the population. If you look at the picture here on my right of this individual, I don't know what he's doing there. It's really hard, but it looks like he's harvesting something very pointy. And you can only work in that sort of thing for so long without having injuries just from the plants themselves. And then quite often there are toxins in the plants. I had a situation when I was running the health center in Michigan where I had ultimately what turned out to be 44 workers trickling in one day to our health center. All of them with huge rashes all over their body, and some of them had the rash on their buttocks and on the back of their legs, and we couldn't figure out why it was so different. And what had happened was they were picking strawberries in a field that had been sprayed for weeds, and the foliage of the weeds were still there in the rows. And so the women that had them on their buttocks were actually sitting on the ground and scooting while they filled their flats full of strawberries. And they were turning into big blisters because they were literally grinding it through their clothes, wet clothes, adhering to their bottoms. And then, of course, the workers that were more able and were standing and were picking had the exposure on their arms. We had to airlift 2 young teenagers out because of their more vulnerability due to age and body mass. Weather, plants, and animals. I'm going to go through these pictures rather quickly because they're somewhat self-explanatory, and I want to make sure we have time to chat. Again, pesticides, agrochemicals, chemical leaching into the groundwater, chemical runoff into the surface water, contaminated clothing. What you see here in this center picture is a young girl and her parent washing their hands at a spigot, and they're washing into a chemical bucket that's been recycled for use in the housing area. Drift also is a critical issue. I was telling someone earlier, we had an incident this past summer in Central Texas where we had a crew from OSHA that were inspecting some fields, and while they were in the field with workers, an adjoining field was sprayed. Everyone was caught in the drift. The OSHA workers immediately jumped in their trucks and drove 45 miles back to Uvalde where they could take showers and change their clothes, and when they got back to the field, the workers were still working in the field. And so, sanitation is a critical issue. Lack of availability of safe drinking water, lack of nearby toilets, and lack of hand washing facilities. Look at those hands. Can you see those hands? And look also at the chest. Look at how thin that guy is. It was in 1986 that we were successful in passing legislation that mandated the availability of drinking water, portable toilets, and hand washing facilities in the field, but only for employers that had 10 or more workers. So if you have several crews of 10 or more working in one field, it's not required because they would be employed by different crew leaders. At times, agricultural risks are compounded. Look at this deposit of petrochemical containers. Again, you see the same one with the child and the recycling. So then, the Migrant and Seasonal Worker Protection Act is enforced by DOL Wage and Hour Division, and quite frankly, these protections are somewhat meaningless to these individuals, in part because of lack of English language understanding, in part because of the fact that they are vulnerable. They often live on the same farm that employs them, and if they speak up about lack of safety in their workplace, oftentimes that means they don't have a place to sleep that night. OSHA field sanitation now requires water, toilet, one toilet and hand washing facility per 20 employees, and safety fittings on some machinery. I'm not going to spend a lot of time on these regulations, but there are regulations that are required. I will tell you that the ability to enforce them is very, very limited, and training is even more limited. In some states, we're lucky if we have 2 OSHA inspectors for the whole state. And those are about enforcing from the grower perspective, not about training from the worker perspective. So we have more laws. Children age of 12 and up, I've mentioned that before. And then the slide on the far left is non-agriculture. So some comparisons there for you. With no guaranteed minimum wage in agricultural labor, but guaranteed minimum wage, which quite frankly I don't know how anybody can live on. Regulations, I'm going to skip through this. I want to get to Farmworker Health. One of the shots from our health centers, when I got started, we were working in cast-off buildings. I opened my first clinic in the lounge of the ladies, adjoining the ladies' restroom in the public health department in Ottawa County, Michigan. But now we have some really great facilities, as you see, adequately equipped, and exam tables and all the good stuff that we really need to do a good job. Again, occupational, environmental, economic, and other factors, what we now call the social determinants of health, often influence the health status of farm workers. They are at high risk for hypertension, allergies, arthritis, dermatitis, diabetes. I probably should have put diabetes first and dental problems first, because dental carries the one truly preventable disease that we have today is a serious, not only dental problem, but medical problem. Excuse me. Because you're interested in occupational and environmental stuff, I put this slide in for you. Dehydration, think about these big fields, 300 acres in size, and you're going to work there all day or all morning long, and you're supposed to drink water to keep yourself hydrated, but there's no place to take a leak, so to speak, except in the field. A lot of other issues that we deal with at the health centers related to heat stroke, insect bites, malnutrition, and of course the ever-present pesticide poisoning. Injuries from repetitive motion, just go do it for a day. I've done it myself, and I usually can't make it through a whole day, but you start in a strawberry field about 4 o'clock in the morning under lights because you want to get things to market early, and by noon I couldn't even stand up from the bending over. I could not do that for a living. Conjunctivitis, gastrointestinal infections, intestinal parasites, urinary tract infections. If you want to know more about what the types of diagnoses are for the population, if you go to the Bureau of Primary Health Care, BPHC website, all you have to do is Google BPHC-UDS. The UDS is the Uniform Data Set, and it'll give you an indication of what these frequent diagnoses are for the population. Again, chronic conditions, these are in alphabetical order: allergies, asthma, cardiovascular disease, chronic renal failure. We see it all. It's not Band-Aid medicine. These are significant conditions that are very, very hard to treat. We find that we can get somebody patched up in pretty good shape, and then it's time for them to move on, and we are not as well connected as we should be as a national network. We still, I can personally book my own airplane seat on any airlines in this country, but we can't transfer records from one electronic medical record system to another. Mental health conditions, very, very significant, often associated with high levels of stress. We find that there's not a very strong recognition of the effect of poverty and continual work on the mental well-being of people in the agricultural sector. And the main reason is because they're running at such a high adrenaline level all the time that to them that's norm. That's their normal. And we need to be conscious of the fact that there are significant repercussions from that, including depression, substance abuse, and domestic violence. Barriers. How many receive health care? This was from a year ago. The data that we had available to us was 800,000. Recent information questions the 5 million estimate, maybe as low as 3.5 million, but nonetheless, we're not reaching them. California is serving just under 300,000, and the next largest state to reach farm workers is Washington. I had pointed that slide out earlier. Access barriers, you name it. Constant mobility, limited income, no insurance, English limitations, levels of literacy, health beliefs and practices. You can read that faster than I can read it to you. But one of the biggest ones right now is the financial limitations that our health centers are experiencing, in which they are unintentionally creating barriers at the front desk because that patient doesn't have insurance. The very survival of the health center itself is sometimes based on their payer mix, their patient mix. Other barriers, limited bilingual staff. In Texas we do pretty good. In New Hampshire sometimes there are challenges. Maine, even in Pennsylvania, it's real hard to recruit bilingual people. Clinic schedule and advertising in English only. You'd think we'd get that right after 50 years. By the way, this is the 50th anniversary of the enactment of the Migrant Health Law. Overbooked appointment schedules, sometimes closed caseloads where there's simply not room for the patient to come in. And in the rural areas that we're talking about, the public transportation systems are very limited. So, we got a lot of barriers here, and I'm not going to dwell on that. I want to go on to the Migrant Health Program. Again, JFK signing into law, that was a really incredible photograph. Some of this is a little repetitive, so I'm going to move quickly through these slides. If you look in the public health section of the law, PHS, if you, again, Google public health PHS, and you'll find the 330 programs, which will detail the legislation that authorizes these. And when I was in college, I didn't really have a lot of time for policy. I didn't really understand it. I hadn't quite grasped the role of our government. The role of our government in opening doors to people. But after I graduated, I became a little bit of a policy wonk and started actually reading the Federal Register. And it is fascinating to see how our government works and sometimes doesn't work. But I encourage you to Google Public Health Service Act 330, because that is our community and migrant health center. Am I speaking too close to the mic? That is our public health, that is our primary care law within the United States. So just to get a feel for where it sits within the government, we are within the Department of Health and Human Services, and we have the health, we call it HRSA, Health Resources and Services Administration, and so that's where it sits. Within public health, we have the Centers for Disease Control, and I need to look for it over here. Kind of hard to find at times. Here it is down here. Centers for Disease Control and Prevention. So we are sister administrations to CDC. And I sit on the advisory council for the advisory committee for the Secretary for health disparities at CDC. And sometimes we speak two different languages. Primary care and and prevention speak two different languages, which is a real problem. We need to correct that. And then within the HRSA, Health Resources and Services Administration, there is the Bureau of Primary Health Care, which is circled down here. So that's where all of these community migrant health centers are run out of. A lot of other responsibilities within HRSA, but the key is health resources and services. It's not end policy, it's not end prevention, it's services. So it's the actual creation of the services themselves. Within the Bureau of Primary Health Care, I relate primarily to the Office of Minority and Special Populations, and these are the divisions that oversee the work that's being done. So if you're looking for jobs in the next year, you might want to go to the Bureau of Primary Health Care because there are opportunities for employment for people like you in our health centers, and we can talk a little more about that. Core elements provide services to the neediest population, have a user majority community member governing board. And what that means is that the county health departments that usually are a little bit better at building roads than they are at providing health care, they don't require a consumer majority on their board of directors. Our community and migrant health centers do, including migrant farm worker representation. So we have some models, what we call a health center model, where it's all under one roof and you have a comprehensive program. We have what's called a voucher program, and these are often run by outreach workers and LPNs, folks who can issue a voucher to a patient to go see a primary care physician in the community, and they reimburse that primary care doc for services provided. And then a combined model, because what we're dealing with, especially in that area in northern Idaho that I was talking about, is we're dealing with seasons that may be as short as 6 weeks, so there's not really any effective reason to put a full-fledged health center in there. So there's an example of a health center model. Standalone, varying size. The chairman of my board of directors is from the Central Valley in California. He has 750 employees and is a $40 million a year operation. We have other health centers that get by on about $700,000 a year. So huge variety in size of these operations. This is a Laredo, Texas mobile unit out of Gateway Community Health, taking services to the farm workers. And we have a list of required primary care services: primary, preventive, emergency, pharmacy, and ancillary. Ancillary being outreach, transportation, and translation, as well as health education, of course. Ancillaries, well, there you got it. Different kinds of ancillary services. You know, I don't want to go into this too much because time is lacking, but will everyone who's signed up be able to receive an electronic copy of this if they've signed up with their email address? So if you want to read this more carefully, or if you want to contact me, I have my email address at the end of the presentation. We have all kinds of service delivery challenges, but I want to move on to what is agriculture, because sometimes there's confusion about who's eligible for migrant health services. So I start with this slide, lost in translation. We use the word migrant workers, and unfortunately in the minds of a lot of our policymakers, they hear the word immigrant. And while it's true that a lot of our farm workers are immigrants, or maybe immigrants, depending on your perspective, we still have a significant number of individuals in this country, home-based in Florida, Texas, California, and Washington, who migrate out, and they are not immigrants. And sometimes that perceived totality of immigrant status hurts our programs in the minds of policymakers because of the anti-immigrant sentiment. So that's the reason for this slide, and just clarification that these words are not interchangeable. So in this picture, can you identify the farm workers? A lot of folks would say, pardon? Yes, that's correct. That's absolutely the answer. Can you identify them based on name or face or ethnicity? Absolutely not. It's not possible to verify the eligibility by looking at faces or names or by stereotyping. So unless you ask, you will not know. Definition of agriculture means farming in all of its branches, including, and this has been a real problem for us because this doesn't say exclusively, it says including, but in the legislation it goes on to talk about primarily horticultural activities, including any practice, including preparation and processing for market and delivering to storage or market to carriers. So this is really, truly farming in all of its branches. Unfortunately, that's been interpreted to mean primarily horticulture, and we are testing the waters and pushing the envelope here, and we are, I'm going to skip through these, we are making sure that our federal government understands from a legal perspective that including doesn't mean exclusively. So while it includes a lot of these types of tasks, we also then move on beyond that to processing, preparation, production, canning, preserving, as well as the, sorry, get my slides right here. Some of these crops don't require as much labor as others because of mechanization, but there's still a human element involved. And we are very interested in making sure that all of our farming communities have access to care. The hops, have you ever seen a hop before? That's what a hop looks like right there. Anybody know how they grow hops? Yes, tell us. Uh-huh. About 40 feet in the air. Yeah, yeah. Uh-huh, uh-huh. So a hops field will have kind of like a loom, but it's 40 feet in the air, and the plants are planted at the bottom with a cord that goes up to these vines at the top, and so that's how they grow. It's fascinating to see if you've never seen it. And yes, still cotton. It also includes dairy farms, production of cheese. This is that God's green earth myth that that it's all safe and we don't need the same kinds of protections that we have in other industries. Processing and packing. Some of these types of crops and processing also happen in large equipment outdoors 24/7 under lights. For example, pickles, the pickle grating. You work in, that's what these guys are doing, is grating tomatoes, picking out the ones that don't qualify. And isn't it interesting to see how green they are? We had some tomatoes on our lunch today, and I unfortunately had to push mine to the side because they weren't quite what I choose to eat. But the reason is because this is how they're shipped. These are the ideal ones. It also includes animal farms, poultry, aquaculture, lumber, and forestry. And we've talked about farm workers, then the seasonal farm workers who don't migrate, the migratory who do, and then the aged and disabled former farm workers who are all eligible for migrant health services. But quite frankly, most of our migrant health centers are now jointly funded migrant and community health centers, which means our community health centers serve everybody. The reason to classify them appropriately is twofold. One is health centers get a little bump up on their funding for them if they're serving farm workers and reporting that they're serving farm workers. And number two, from a clinical perspective, we want to know who they are so that we can treat them appropriately. If they're going to leave in a month, we want to know that so we know what our window of opportunity is. And if they're engaged in agricultural work, we want to know about that too. So, I'm done. And I'm open for questions and discussion. Now's the time for our chat. Thank you. So I know some of you are interested in pesticides. I'm not an expert in pesticides, but I've had some firsthand experiences with workers who have been exposed. You want to start with pesticides?
Or other questions?
Yeah.
So my grandfather was a bracero in Chihuahua, and he told stories of when they made it to wait to be selected, they were sprayed with some sort of white spray that was supposed to disinfect them. And I wondered if this was just his story or if there's a lot of work on this being done to the large number of braceros that were waiting to be selected.
Well, I didn't know about that until probably 1982, when the public health officer in the county where I was working in Michigan came for a meeting in one of our clinics, and it was the basement of a church. And he said, "Oh, I remember this room." And he walked over and he got the extension with a contraption on the end that was used to change the light bulbs way up high. And he said, "We used to use this to spray workers with DDT when they arrived. And we would use this hook to pull, we had them stripped down to their skivvies, and we used this hook to open their drawers so that we could spray the DDT in all of their private parts because they were spraying for body lice, whether or not they had them." The public health officer telling me that story in 1986. So I'm sure it happened on the border. I'm sorry I don't have a picture of that, but looking at the way they did the fingerprints and the vaccinations and the physical exams, it wouldn't surprise me at all. Thank you for that anecdote. Yeah, and according to the public health officer, that white stuff was DDT, which is of course now banned. Yeah. Yes. By the way, the author of the book that I was trying to remember, who wrote Macho and has written a whole series of books around the Mexican-American experience in agriculture in Southern California, is a guy by the name of Victor Villaseñor, and he teaches at USC. He writes novels. They're novels. They're very easy reading. Reign of Gold, a story about his family. So Victor Villaseñor. Yes?
I was struck by the fact that the law still allows children so young to work if they're farm workers. Now, that probably goes back to a day in the 1800s when there were legitimate millions of small family farms and they really needed those kids working. That's no longer true. Why do you think the law has not been changed? What's the motivation to keep those kids working instead of getting them in school or wherever they should be?
Well, we're actually working with the National Children's Center out of Wisconsin at the University of Wisconsin, in fact, affiliated with one of the ag centers there in Wisconsin. And we're having a really hard time with this because the opposition to changing that law on the part of the farm worker families themselves is so great, because those parents want their children with them. They want to know where they are, and they want to teach them the work ethic, and they need their earnings. So it's from within the farm worker families themselves that we get the greatest opposition. But just like we fought that battle about field sanitation in the 1980s, we are refighting the battle around child labor right now as we speak. So National Children's Center out of Wisconsin, if you want to know more about it. Any other questions, comments, stories? Yes, to hear.
On. I'm fine. Oh.
Can you all hear her question?
Oh, you're recording it. I'm sorry. I wondered if you could talk a little bit about retaliation for complaining about working conditions, or, on a large scale, on a small scale. It's a big question, but maybe you have some anecdotes.
Okay. Well, the first thing I would like to say is that there are different kinds of farms. In the west of this country, we have a lot of huge corporate farms, and in the Midwest and the East, we have more small family farms, although we have some of each all over the country. The way workers are treated differs by employer, and I think there's a lot less humanization of the worker in the large agribusinesses than there is in the small family farms. I know small family farms that are very humane and very concerned about their workers, and they understand that their workers are an asset and that they have to preserve that asset. That asset is being challenged more and more because of immigration laws. It's not unusual for employers to lose their workers due to immigration, so they've learned to protect their workers in many aspects, and they want them healthy, they want them capable, and the issues that are brought to their attention by workers are usually corrected. many times workers will not bring those issues to the attention of their employer because of fear of retaliation. So there's a little bit of everything going on, but I will tell you that retaliation, actual retaliation in the 1960s was a lot worse than it is right now. And a lot of that has to do with labor shortages, the appreciation for the workforce that they do have. So there was another question back here, the lady right behind you, yes. And then we'll go back to the back of the room.
I was curious your thoughts on how it seems like race and citizenship status might play a role in the lack of integration in this movement. I mean, the Migrate Health and the larger labor movement for fair, more just practices.
Mm-hmm. Well, definitely. I said to someone earlier this morning that what we have here today really and truly is the modern day evolution of slavery. So we had a huge dependence on slave labor as a developing nation. We recognized that that was inhumane, and then we continued to use those same people in almost as abusive and sometimes more abusive way after that. The only difference was the legal issue of ownership. And when that source of cheap labor was no longer available to us, we moved to many other populations. And we've talked about the Anglos who are derogatorily termed as Okies and Arkies from Oklahoma and Arkansas, who moved during the Dust Bowl days. I'm going to jump around chronologically, if you'll forgive me. We have railroads which would not have been built other than the Chinese laborers who came to work in very, very austere conditions, and there was an equally derogatory term for them. We have had similar waves of immigration in the Northeast in particular, coming from Europe with the Italians. And I think you've got a strong Italian presence here. And I love working with my folks in New Jersey, my health centers in New Jersey, because that Italian population understands that this is just another wave, and they have a strong sense of embracing the new members of their community and recognizing that it's a part of the vitalization and sometimes the revitalization of their communities to have workers come in to replace people who have migrated out. But all over the country, we still have major issues related to prejudice. And whether we're talking about Haitians, whether we're talking about African Americans from the Deep South who migrate, or whether we're talking about Hispanics from Mexico or Puerto Rico, there are some communities that are accepting, and there are some communities that are highly prejudicial. And right now, what we've got going in our country is this fervor, this sense of blame of immigrants for everything that's wrong with our country, when there are much bigger and more serious issues that we need to deal with. And we're sometimes silenced or blinded from looking at those and recognizing those for what they are because of the fervor and the drum beating that goes on in the anti-immigrant sentiment. So yeah, a lot of racial and ethnic prejudice going on. They're sending our money to Mexico, regardless of the contribution that they make while they're here. Okay, there was another question at the back of the room.
First, thank you for this. It's great. Also, thank you for unintentionally previewing my question. My question is about slavery in farming. In about the last 2 years, slightly before that, one group that's been publicized as particularly abused are the workers who pick tomatoes in Florida, where it's overt slavery, with Hispanic workers being shackled, bought and sold, beaten, and sometimes killed. And their book's been written on this site. I forget the author, you might know. Are there other locations and industries where it's where this particular problem is bad and that you've noticed or that you would mention?
Well, first of all, I think you're probably talking about Collier County, Florida, which is where I believe that's taking place. And there is a strong activist group there called the Coalition of Immokalee Farm Workers that you might want to check into. Again, Google them. They're pretty well organized. They've been doing some of the stuff that we did back in the 60s. They've been doing now in this decade around boycotting and picketing and trying to get Burger King in particular to up the amount that they pay for a bushel of tomatoes by 2 to 5 cents. I don't remember the exact number. Something that would make a significant improvement in the earnings of the workers and a small increase in the cost of our hamburgers. There are areas in the San Diego, California area where I see very similar parallels. That is probably one of the wealthiest counties in the United States. And in the shadow of multi-million-dollar homes, there are people living in holes in the ground, literally living in holes in the ground, covered with cardboard, and going out and doing whatever day labor, primarily agriculture, that they can find work to do. And these are almost all recent immigrants. There's a lot of filming that has been done on them, and I'm going to recommend a documentary by the name, I don't remember the name of the documentary, but the producer is Carlos Frey, F-R-E-Y, and he's done a lot of work in those areas. I don't know of other instances in which people are actually shackled, but I will tell you that there are areas, and I've experienced it myself personally, where there are crews of people, not just immigrants, but crews of people that are moving around conducting agricultural work under the auspices of a crew leader who keeps them down and out. Basically, that crew leader is the sole source of their work, their transportation, and their food. And I worked with one such group that I never even knew existed in my own backyard, literally in my own backyard, that was brought in from Chicago. They were picking homeless guys up, Anglos and African Americans, up off the streets of Chicago, and just transporting them about 150 miles into southwestern Michigan, and keeping them hidden in the back of a farm and living in incredibly austere conditions. So even if they're not shackled, the fact that they are basically paid in alcohol, and kept working and then returned back to the streets of Chicago at the end of the season is a strong indication. We had another crew of largely women that were coming up from Alabama, African American women, and I never knew they were there for years until a bunch of them got pregnant and they started bringing them in for prenatal care, but we never saw them for anything else except right before delivery. So yeah, it still goes on today. There was a question over here on this side of the room. Okay.
Hi, thank you for an excellent presentation.
Thank you so much.
I'm wondering if your group or another group that you're aware of has tabulated in more detail the occupational, different types of illnesses, injuries, fatalities, to get some idea of the extent of it. And then the other question was in terms of OSHA. What are the events that are likely to bring OSHA in? Is it basically for fatalities only or for other?
Or getting sprayed. Or getting sprayed. I'm embarrassed to say that the majority of the analysis, the research that has been conducted about this population within our health centers has been individual practice-based research. And as such, it doesn't give us the big picture. And even the UDS that I was telling you about is aggregated in roll-up data. And so it makes it very difficult for us to ferret out the details for the farmworker population. I'm proud to tell you that we have been a recent recipient of a grant from NIH for the purpose of creating the research infrastructure to allow us to do this. And last week we did our first data dump from 2 health centers, one in Colorado and one in New York, large migrant and community health centers, and we have gotten all of the data for all of their patients, not just the farm workers, because we want to do comparative analysis. We dumped it into a data firm that we're working with, which is based out of Seattle, Washington. You may know about Battelle. which is a very reputable and firewall data firm. We've gone through all the IRB studies that certifications that we needed to get in order to get patient data with identifiers. And the plan is to add, and by the way, those two health centers, we had one electronic medical record. And see, that's the key, is most of our health centers are only just now, under health reform, going for what's called meaningful use. Does that ring bells for you? And so they're being incentivized to adopt an electronic health record and then use the results of that in a meaningful way to change their practice and improve their performance. So as those health centers are coming on board and achieving electronic health records, we now have something that isn't on paper that we can begin to analyze. So we've dumped data from 2 large health centers, all using eClinicalWorks. The next one will be NextGen, is the name of the next software that we're going to use. We haven't finally selected the next 2 health centers. This demonstration project will only collate data from 6 health centers. Using 3 different software programs, but then to create the interoperability and the ability to analyze data on different platforms for all of them. We've selected a set of data fields that we want to make sure they all have in common. But the thing I have to tell you is that the developers of the electronic software for the electronic medical records are not including occupational and environmental health in their data fields. The health centers have to go back and pay the EHR programmers to add fields for occupational and environmental risk. And quite frankly, we need that for all of our patients. It's not just about, is it a workers' comp claim? It's about understanding the health status and the influences on the health status of those workers. The other thing I might point out, in case you're not aware of it, there are very few vital statistics bureaus in this country that record mortality. When they record mortality, give an indication of occupation. So it's missing at all levels. So how we say that agriculture is one of the 3rd most dangerous occupations, I frankly haven't figured out. But we know that occupation, construction, and mining are the 3 most dangerous. I think we're missing the boat by not documenting not only current occupational status when a death occurs, but for an infant, family occupational status, and previous occupational status. So, thank you for your question. Did I answer it all? Okay, thank you.
Great. Well, thank you. Before I hand the microphone over to Dr. Frank for the conclusion, I just wanted to remind the students that Susan Reverby will be our next Grand Round speaker. She'll be coming on Thursday, April 12th, and all of you should probably be familiar with her work since you discussed her book in Mike Udell's class.
So don't forget there are a few more documents up here on the front table and a few more magnets.
I think you've gotten a sense of something that we don't often think about or address, is where our food comes from and who prepares it for us. So hopefully you have a better sense of that. I couldn't have thought of anybody better than asking Bobbi Ryder to come here and share this with us. This has been her lifelong work. She's been engaged in it, clearly deals, throughout the country with this, gets into the halls of Congress and the White House to advocate for this. And just by way of conclusion, I know Bobbi wouldn't mind, take her email right to her. She has a staff. They have a library of materials there, most of which is online. The publications that we're handing out, they've been around for a long time, but they're now only, unfortunately, electronic. These are last year's and the last of the print versions. One of them, the newspaper-looking one, is a health document for farm workers that's bilingual. The other is the Newsline, the newsletter that gets put out, I believe it's quarterly, for health professionals. There are also meetings, again, for those of you that are thinking about careers. There's plenty of work to be done in this arena. There are national meetings that address the issue of farm worker health. There's the Midwest Stream Forum, the West Coast Forum, the East Coast Forum. All of that would be available to you if you go to the website for nchf.org. Just a last round of applause for our speaker today. Thank you very much.